Hello dear colleagues, I am Dr. Subramanya NK, Professor of Pediatrics and Honorary Secretary of Indian Academy of Pediatrics Respiratory Chapter. Warm greetings from Bangalore, and we welcome you all to a modular series on diagnosis and management of pediatric asthma. We will be taking you through a journey of series of videos which will give you a comprehensive overview of diagnosis as well as management of pediatric asthma in practice. While this video would be a ready reckoner for you in practice, you can view this at your leisure times in your clinics or in your office practice and see that some amount of reinforcement of knowledge update happens in pediatric asthma. This is all I have to say from the desk of secretary, and wish you a happy learning in asthma. We will go through the module in the form of case scenarios so that the messages that we convey for you would be better delivered and our communication and understanding is made much better. The first session will cover on diagnosis of asthma, and let me take you to the most common scenario that you see in practice. Let's say a 5-year-old Jose walks into your OPD with mother, and the mother complains that frequently she has been bringing to you for cough and cold, and the colds rapidly go into the chest. And to make the matters worse, he is accompanied by grandmother who bargains for everything and she wants the best out of you. Is it not a common scenario in your practice? Yes. Now, there will be questions which will be raised by the grandmother, and there could be questions within the minds of the pediatrician who is treating, and ultimately all these questions boils down to two things. One, is Jose suffering from asthma, or Jose is not having asthma? These are the only two scenarios that we'll have. Let's see how you can get into the diagnosis of asthma or no asthma in this particular scenario. What questions you will ask to the mother or the grandmother to ascertain the diagnosis of asthma in Jose? Basically, asthma is a chronic inflammatory disease, and it presents with recurrent cough, cold and less of fever, and we need to specify and ask the questions on cough, cold, wheeze, breathlessness as symptoms to ascertain the diagnosis, and that's exactly what you are going to do in the practice. So your questions will be multiple, but can I take you through the series of questions that you would usually ask? First, you ascertain that the symptoms are recurrent but not persistent. How do I know? For example, the symptoms start and never come down but goes on increasing, and there are no intervals. That means the symptoms are persistent, and you have to look at some other disease but not asthma. Asthma is characteristically characterized by recurrent symptoms, and when the symptoms are present over a period of time and they are recurrent, it is all the more easy to ascertain the diagnosis of asthma. It's very easy in children older than 5 or 6 years, but may be difficult in younger ones when the symptoms of asthma overlap with seasonal colds, which are normally recurrent in that age group, and that I would address to you in a separate section on under 5 wheezing. But right now we have a 5-year-old Jose in whom we are going to ask that these symptoms are episodic. That means we have a interval free period in which relatively Jose doesn't suffer from symptoms, and so I am going to ask questions to the mother to further delineate and elaborate on the symptoms that Jose is suffering from, particularly cough and wheeze. These are two cardinal symptoms, and relatively breathlessness. It depends on the age of the child whether it will be able to describe breathlessness, and let's see how we can go through it. First of all, let's come to the cough in Jose. So first we need to ascertain that the cough which the mother is complaining of and the characteristics of the cough. And there can be two types of cough that you would see in practice. Let me show you the examples of cough. This would be a pharyngeal cough or an upper airway cough, which would be very common. But I would take you to the second type of cough. This type of cough, which would all the way makes you clear that you are referring to a cough which is relatively coming from lower airways. And the type of the cough is like cough can be isolated, for example, or it can be a progressive type of cough, and which happens in bouts, which is typically described in asthmatics, as I would show you in the examples. And often this ends up with vomiting. This question, if you ask the mother, she would definitely bring out the history to which type of cough she is referring to, and maybe you can mimic in the OPD and give her the example as to which type of cough she is referring to, or you can make Joe's cough and see exactly what is the type and nature of the cough that you have been seeing. It's very, very important to know the type of the cough that you are referring to. You need to ask the duration of the cough. Let's say the cough lasts for a week, and over a week or two, the cough shows a declining trend. Initially, in many of the upper respiratory tract infections that you see in day-to-day practice, initially there will be a brief episode of fever, followed by cough, and this cough would last for a week or two, but 50% of the cough will come down by a week, and nearly 90% by 2 weeks, and hardly there will be any cough by end of 2 weeks. So if you see a progressive declining episodes of cough over a period of time, this would be referring to a routine, seasonal, or a routine practice cough that you would see. But in a child with asthma, you would see that these coughs do not get resolved so easily, and you will see the parents getting frustrated in your clinic and begging for something or the other for the cough. So therefore, you must ascertain the duration of cough. Generally, the cough will be more than 10 days in children with asthma. Once you get a cough, they will not go so easily. You need to identify whether these coughs are more in the day or night. More often than not, the mother would tell us that nights are disturbing, and you will have these episodes being referred to as nocturnal cough. Mind you should be very careful. Any cough cold can worsen in the night in a child, but that does not refer to nocturnal cough. If you have a cough that is isolated and occurs only in the night, that is referred to as nocturnal cough, and you should elicit this history. You must also ask the mother if this cough is activity induced. Let's say Joe runs for a while and then sit down and starts coughing. This would also mean that the trigger is the activity. So what I am trying to just briefly tell you about story of the cough is the cough typically occurs in bouts? Is the cough recurrent? Is it episodic? Is it nocturnal? Is it activity induced? Is it seasonal? So these factors would qualify a cough and make the diagnosis of asthma more probable. Let's come to another symptom, wheeze. Wheeze is often both a symptom and a sign. Please beware of the mothers who refer to any respiratory noise as wheeze, and they may or may not be specific. This typical gora sound which a young infant makes, or in our local language they refer to kapham, balgam, so on and so forth. These may not refer to a wheeze, whereas wheeze is a typical musical sound, and you must ask and qualify for the wheeze. Wheeze can be of two types. It can be monophonic, which means there is a fixed airway obstruction and you would get a wheeze. For example, something like this kind of sound that you get is a monophonic wheeze due to a fixed airway obstruction, in contrast to a polyphonic wheeze due to multiple variable obstruction that happens in the airways. And I will show you an example of a polyphonic wheeze which you should demonstrate and ask the mother to identify if she were to be referring to this type of polyphonic wheeze. This type of wheeze is a polyphonic wheeze which is very characteristic of asthma, and often mothers are able to identify, and a smart pediatrician would also quickly auscultate and find out if what she is referring to is a polyphonic wheeze. And just like cough, the wheeze can be episodic, wheezes can be more nocturnal, activity induced, trigger induced, seasonal, so on and so forth. And wheeze and cough, when they are together, that makes the probability of diagnosis of asthma very high. Difficulty in breathing or breathlessness is often a less described symptom in younger children, but more so in an older children, and the child should be old enough to describe the symptoms of breathlessness, which is relatively subjective and which is felt. And this difficulty in breathing could be, for example, an exercise induced or activity induced, or it could be nocturnal. And this is very, very important. So basically what we are trying to do is to ask for, does this child has symptoms of airflow obstruction and airflow inflammation? So airway inflammation and obstruction are the ones which will produce these symptoms. And then you need to ask further questions. Sir, can this cough and wheeze can be there in diseases other than asthma? Answer is very much yes. But then, how do I say this Jose has got asthma? So basically for diagnosis of asthma, you need further qualifiers, or these symptoms have to be qualified further. How do we do that? This cough, wheeze are often afebrile episodes. These episodes do not have much fever. A small degree of fever can come and go. For example, if there is an upper respiratory tract infection that is flaring up is flaring up an episode, and then you will have a mild fever that is accompanying, but that doesn't mean that this is a febrile episode. So basically majority of the episodes which the mother is describing, if they are without fever, then asthma is more likely. There could be an atopy in the child. Atopy is a very, very common symptom which is often underdiagnosed by many pediatricians. You will have a dry skin which is very, very obvious to see, and you smartly look at the parents, and the parents also may have atopic dermatitis in your office when they are accompanied by the child. You may have flexural dermatitis, or you may have features of atopy that are present on the extensor surfaces of the body. It's very easy for you to ask the history of itching and the symptoms referable to atopy, and this history should be elicited by every pediatrician when mother presents with the episodes of cough and wheeze. You must also ask about the family history of asthma. It's very, very important, and you should have smart ways of asking the parents, do you have asthma? And I have seen in my practice, whenever I ask the parents, do you have asthma? Often the parents deny. They say, no sir, we don't have. That is simply because the parents are apprehensive whether their child Jose will be labeled with asthma. And it's very, very important for you to understand the sensitivity of a label of asthma in the parents, and therefore ask the questions. You should gently ask the questions referable to symptoms of asthma, then straight away asking, do you have asthma? Then they will say, I don't have asthma. So I see a lot of mothers or parents telling me, sir, I don't have diabetes, but I have mild sugar. You know what they are actually referring to is very, very important. I would smartly ask the mother, do you have dust allergy? Then she will say, yes sir, I have dust allergy but no asthma. She may say, sir, I snore but I don't have asthma. She may say, my father snores, and the father may confess, yes, I do often have, I used to have some colds in the past, sir, now I don't have. You know, there will be various ways in which the parents react to you, and you should be a smart pediatrician to elicit the history of allergy in the family. There could be a specific allergy, a type 1 hypersensitivity or symptoms referable to asthma or allergy or atopy and or allergic rhinitis in the family, and you must ask the history of family history, and it's very very important. What we are doing by asking the family history is basically we are looking at genetic predisposition in this particular child. So therefore, when I say cough and wheeze, they are referable to symptoms of airway inflammation and obstruction. By a positive family history, we are giving to a genetic predisposition to the same symptoms to ascertain and make our diagnosis of asthma more affirm. You need to ask for seasonal exacerbations. They will quite smartly tell, sir, he is very much fine but gets it in Diwali, gets it in December, gets it in summer, or quickly when there is change of seasons they would get. This is simply because in seasons you have two issues. In seasons, in particular season you may have particular viral infections more common, and viral infections are triggers of an asthma. And secondly, in some seasons some of the allergens in the form of pollens may be more common, and therefore you may have asthma. In any case, seasonal variations of the episodes are characteristics of asthma, and you need to ascertain. Lastly, I would say please ask if there is relief with bronchodilators and or steroids. This is a very very important question. Please ask what was done in the past for Joes. Mothers may smartly tell that, so frequently I went to pediatricians, they used to nebulize him and he used to get better. So this smartly tells us that he was responding to bronchodilator. A small word of caution for response to bronchodilator. Please do not be carried away by the fact that you gave bronchodilator for 3 or 4 days and then it responded. Then it could be a self-limiting disease. So there should be a quick and a predictable response to bronchodilator, which is very very important. For example, this Joe walks into your OPD with wheeze and cough at 7 o'clock. You nebulize him or you give him MDI with spacer, a bronchodilator, particularly salbutamol, and within 5 or 10 minutes he is fine. He doesn't have cough, he doesn't have breathlessness. This is exactly what we are referring to as relief with bronchodilator. Not prescription of salbutamol for 3 or 4 days and at the end of the week the Joes became better. So please ask this question, and even the response to steroids. If somebody is given steroids in the past and quickly within hours or within next day after giving steroids, if he becomes better, definitely this would qualify for a diagnosis of asthma. It is very very important that you ask all these questions in history. It doesn't take time for you. All that you need to ask is make sure that you ask all these questions, not 1 or 2 of these questions and jump to diagnosis. You need to examine him to find out. What will you find when you examine RP? As I have told you, you can make him cough and see. You may have a polyphonic wheeze if he is in flare-up. You may have a prolonged expiration. You may have him in distress, particularly with accessory muscles working, in case if his flare-up is quite moderately severe or severe. But otherwise, if he is coming in the interval period, this particular Joes may look entirely normal, and it's very very important for you to ascertain that and understand that in the period when he is there in your office, he may be essentially normal. Quickly you can examine for evidence of atopy. Examine him completely. He may have the red eyes, running nose, he may have flexural dermatitis and all eczemas, and all these are very very important for you to make diagnosis of asthma. Should I quickly send for investigations? I will answer to these questions in the next module of mine, but essentially I want to tell you that in quick summary, your investigations which you would quickly comes down to your pen like CBC, eosinophil count and chest x-ray are not very very value additions to your diagnosis. At the best, they may help you in ruling out some other diagnosis that you may have in your mind, but otherwise diagnosis of asthma is essentially clinical. And remember that a smart clinician can make a diagnosis. You don't need any equipment, you don't need a big laboratory, you don't need a big setup, you don't need a big qualification for diagnosis of asthma. All that you need is smartness, lot of common sense, and you need to spend time to ask questions. I would certainly want all of you to ask all the questions that have been deliberated, particularly whether it is episodic, whether it is relatively fine in the interval period, whether the episodes are a triad of cough, wheeze and breathlessness in various permutations and combinations with qualifiers that I have told you, with plus or minus relief with bronchodilator and or steroids. Hope that this session made you smarter in making diagnosis of asthma in an older child, while I will refer to you and take you through a session on under 5 wheezing where I will help you to make a diagnosis of asthma in younger children less than 5 years. But more or less this session would have helped you better in making diagnosis of asthma easier in your practice. Lastly, to sum up, I'll tell you, diagnosis of asthma in office practice is essentially clinical, and wish you all the best in making diagnosis of asthma in your office practice. Thank you.